Welcome and thank you for joining us today. My name is Kalina. I will be the moderator for today. And today's webinar is jointly organized by the Canadian Hepatitis B Peer Support Group and the Toronto Liver Clinic Chinese Hepatitis B Support Group. I'm the co-chair of the Canadian Hepatitis B Support Group. I'm also a member of the Toronto Support Group. Now, my co-chair is Dr. Hin Ko, who unfortunately is unable to join us today. So because today we do have simultaneous interpretation, so you will notice that I am speaking at a slower pace so that the interpreters can catch up with us. I'm very happy to introduce to you our guest speakers today, Dr. Anna Locke. Dr. Locke is a professor of hepatology in the Department of Internal Medicine in Ann Arbor, Michigan. She received her medical degree from the University of Hong Kong, underwent training in London, UK, before moving to United States in 1992. Dr. Locke has a special interest in hepatitis B, particularly focusing on its natural history, treatment, and the prevention of liver cancer. Throughout her career, Dr. Locke has received many distinguished awards for her contributions to clinical practice, research, education, and the liver community. There are just too many awards for me to list them here today. She is an internationally recognized and respected liver specialist. We are very honored indeed to have her with us today to share her insights on the future of hepatitis B. So let's welcome Dr. Anna Locke.
Well, thank you very much, Kalina, for the kind introduction. So let me see. Share. Okay. Can you see my screen now?
Yes, we can see it.
Okay. All right. So good morning or good afternoon, depending on which part of Canada you're in. I'm very delighted to be able to talk to you all about hepatitis B, a topic that I've been really studying for more than 40 years. And today we're talking about what is new, what is on the horizon in the future. So I'll talk a little bit about vaccination, and the focus really is on treatment. In particular, different societies are updating the guidelines and trying to broaden the number of patients that might be eligible for treatment. And many of my patients in the clinic ask, is the same old treatment all the time? When are the new treatment going to be available? And we will talk a little bit about those new treatment as well. So first, let's talk about vaccination. Why is it important to talk about vaccination? Because hepatitis B is an infectious disease. We can prevent it, and we have safe and effective vaccines that have been available since the early 1980s. So it's been around a long time, and worldwide, more than 100 million doses have been administered over the decades. We know that it works very well, and the hepatitis B vaccine is usually given as 3 doses, and 95%, which is close to 100%, of infants, children, and young adults, after they finish the vaccination, would get immunity, which means that they have high enough levels of antibody that should they be exposed to the virus, they would be protected and would not be infected. Well, unfortunately, the 95% is not for everyone. And if you're older, with vaccination, older really means above the age of 40, which applies to many of us. Those with suppressed immune system, for example, patients on cancer chemotherapy, the immune response would be lower, but also patients with chronic diseases, such as diabetes, chronic kidney disease, patients with cirrhosis, and patients with HIV infection. Their response to the vaccine is not as good. This is the reason why getting people vaccinated when they're young and before they have these illnesses would give you the best results. Now, hepatitis B vaccine is not only effective in preventing infection, but there have been several studies now that show that, in fact, by preventing infection, you also prevent hepatitis B related liver cancer. Everyone knows when people get hepatitis B, the one thing that they dread the most is liver cancer. But if you prevent infection, then you also prevent liver cancer. But vaccines work only when you use it. It is like medications. A lot of times we find that there are medications. The doctors prescribe the medications, but the patients don't take the medications. And so you cannot get good results if you don't take the medications. And similarly, we have safe and effective vaccines, but if they sit on the shelf, in the freezer, in the fridge, and they're not used, then they won't do anyone any good. So it is extremely important that every country health department has the right policies and the right infrastructure to make sure that the policies can be implemented. So up until a few months ago, with all these crazy discussions about changes in the US, the CDC recommendation for hepatitis B vaccination is to make sure that we vaccinate all the newborn babies, regardless of whether the mother has hepatitis B or not. And especially if the first dose of vaccine is given within a few hours, best within the first 12 hours of birth. Now, we know that if the mother is infected, then the risk of passing the infection to the baby is very high. But even if the mother is not infected, we cannot be sure that the baby would not be exposed to hepatitis B virus through other people. For example, it may be the nanny, it may be the grandparents, it may be the father, it may be the daycare staff, it may be the daycare children that your baby might be exposed to. And this is the reason why it is best to make sure that regardless of the mother status, all babies get vaccinated as soon as possible after they are born. But the CDC also recommend not just the babies, for every kid, every adult, if they had not been vaccinated before, and if they're not known to be infected, they should also be vaccinated. Now, this is very similar to the policies recommended by the Canadian guidelines. And everyone recognizes the importance of the vaccination. Now, those of you who have been watching the news realize that crazy things happen south of the border. One of the things is the CDC with new people in charge start wondering whether we're giving babies too many doses of vaccine. Maybe some of them are really not necessary. In particular, what they focus on is if the baby is born to a mother who is hepatitis B surface antigen negative, these people say, well, if mom is not infected, the risk to the baby, at least early on, isn't all that high. Maybe we don't really need to have the baby get a dose of vaccine. They're not saying no, but they're also not saying yes. What they propose is shared decision making, which basically said, well, instead of automatically giving the baby the shot, you would then have a long discussion with the parents. Well, you can choose to have the baby vaccinated, or maybe you can choose not. And if you choose not, then the baby can wait a few months before they get vaccinated. Because the rest of childhood vaccination, like to tetanus, typhoid, diphtheria, and all that, doesn't start until 2 months. So the CDC had recommended in December and January, if mom is not infected, don't worry. You can decide to go yes or no or delay it. Now, thank God they realized that if mom is infected, the risk is very high, and they're not making any changes. That the babies should still get vaccinated as soon as possible after they are born. Now, if those recommendations had stayed, then what we worry is there will be delay, or some babies are not going to get vaccinated, because it is very difficult to really have these complex discussions with parents. The advantages and disadvantages, the effectiveness, the safety, because everyone is so busy. And not all doctors and not all nurses are really trained to have these discussions. So what we worry is there will be delay, and some of the babies are going to end up not getting the vaccine. And you say, well, so what? But the baby might not get infected. Well, some of the babies might never get infected, but some of them will. And why do we focus so much on that early period, within hours of the babies being born? This is because these newborn babies, their immune system is not fully mature. And if they get exposed to hepatitis B, they have a 90% chance of developing chronic infection. So 9 times out of 10, if a baby from birth to a few months get exposed to the virus, get infected, they're going to get chronic infection. And we know once they have chronic infection, they're at risk of cirrhosis, liver failure, and liver cancer. Now, way back, for those of us who were older, when we were born, there was nothing available to protect us. But now we have something very safe, very effective. Why are we not using that to protect our next generation? Even if the chance is low, but if we can prevent it, we should try. Now, again, if you've been watching the news, thank God, the American Academy of Pediatrics, which is basically the national society representing pediatricians, they took the U.S. government to court, and the judge said, we agree with the pediatricians that the government recommendation to pause all these vaccinations to make it optional is not right. These folks who make those decisions are not qualified people. So right now, those new rules have temporarily been paused, and we hope that we will get this resolved because we hope that the US, like Canada, like the rest of the world, will continue to protect our babies and the next generation. Some of you may say that who cares what happens down south across the border? Well, we know that the world is very interconnected. We knew that very well during COVID. Something that happened in one part of the world for infectious disease very quickly can affect other parts of the world. So we're also paying attention to what happens. Now, I'm now going to switch over to talk about treatment. Many of you know that we have treatment for hepatitis B. I think that in Canada, like in the US, interferon is very rarely used. But in China, it is very commonly used. This is an antiviral, but it has to be given as injections, and it has many side effects. That's why most of us prefer the oral antiviral. These days, we use the new ones, entecavir or tenofovir, which is either in the form of tenofovir disoproxil fumarate or Viriate, or tenofovir alafenamide, TAF, or Vemlidy. These antivirals, you can see, they have been available for 20 years. So every time I recommend a patient to start treatment, they always ask me, how long have these medicines been around? Are you sure it is safe? Because I'm feeling okay now. Don't put me on anything that might give me problems later on. But we really have hundreds of millions of people who have received these treatments, and we have safety data for more than 20 years with entecavir and tenofovir TDF Viriate. And those, some of you might have been on treatment for a while, or know of someone who's been on these treatment. And you know that they work very well. They're very effective in suppressing hepatitis B virus. So when patients are put on treatment, we can see the hepatitis B virus DNA, which is a measure of how active the virus is, quickly goes down. And for most patients, after 1 to 2 years of treatment, the DNA is suppressed to below detection. But we always remind the patients, not detectable in the blood does not mean that it's gone from the liver. So never ever try to stop treatment without talking to your doctor, because when you do so, the virus in the liver would spring back to life and can cause severe flares. Well, these antivirals not only suppress the virus, but because they suppress the virus, they reduce liver inflammation and injury, and over time also decrease fibrosis or scarring, and in turn prevent cirrhosis and liver failure. They also decrease the risk of liver cancer, but the risk is not completely gone. And this is the reason why, even for patients who've been on antiviral for a few years, DNA is suppressed to undetectable. We would not say, oh, don't worry about liver cancer screening. We say you still need to do liver cancer screening for many patients who are older, or for patients who already have advanced fibrosis or cirrhosis before we put them on treatment. Now, I mentioned that most patients and most doctors choose to use the oral antiviral and not interferon because it's simple. You just take one pill once a day. And we now have generic versions of entecavir and TDF, which means that the cost is relatively low. And we have, as I say, 20 years of safety data. But these drugs are mostly suppressing the virus. They do not completely get rid of the virus. And this is the reason why, even when the virus DNA is not detectable in the blood, there's virus still hiding in that little corner in your liver. And therefore, we would tell the patients, you got to continue treatment. If you want to stop, we need to have a really heart-to-heart talk to see whether it is safe and how frequently we need to monitor so that if the virus should spring back, we can put you back on treatment. Many of you know that the diagnosis of hepatitis B starts with testing for the hepatitis B surface antigen. So this is a blood test, and if it's positive, it indicates infection. When it goes to negative, it means that we done a pretty good job and really controlling that virus. And ultimately, with antiviral treatment, we hope not only to suppress the DNA to undetectable, but to actually get rid of the hepatitis B surface antigen. Unfortunately, with current treatment, we have a very low success rate. So even after 5, 10, 15 years of entecavir, tenofovir, less than 10% of the patients would clear surface antigen. This is the reason why most patients need to be on treatment for years and years and years. And as I've mentioned, the risk of liver cancer is decreased, but not completely eliminated. So many patients say, why can't you guys do a better job? Find us better treatment that is truly curative. But before I go to that point, the other issue that patients are pushing us is, I have hepatitis B, and I know that I've had it for a long time. Why is it that my brother's doctor say that he should be on treatment? And my doctor say it's okay to keep an eye and monitor you, and you don't need to be on treatment. Well, hepatitis B is a dynamic situation. And for some patients, if your immune response recognizes the virus and does a good job in suppressing the virus, and you have very low virus DNA level and very minimal liver injury, and you are a compliant patient, keeping an eye on you is okay. And we can start treatment only when the virus goes up and when the liver enzymes go up. There are also patients who are very lucky. And sometimes during the course of the infection, the immune system gets stronger. And all of a sudden, next time when they come back, we find that the virus has gone down and the hepatitis B markers might have gone from positive to negative. So this is one of the reasons why most guidelines would not say you need to treat everyone, but rather would say we should really assess if the patients have cirrhosis, which means advanced liver damage. No question asked, everyone should start on treatment. But for people without cirrhosis, we say that if the virus DNA is high, it's usually more than 2,000 or more than 20,000, depending on whether the patient is also hepatitis B, E antigen positive, and if the liver enzymes are higher than normal, they should be on treatment. Or if they already have signs of fibrosis, they should be on treatment. If they have family history of liver cancer, a brother, a sister, a parent with liver cancer, then don't wait until the virus DNA is high. Don't wait until the liver enzymes are high. They should be on treatment. Well, that's what we've been recommending for many years, but we've heard from patients, well, if my DNA is not so high, my liver enzymes is not so high, but I'm really terrified because I have many friends and relatives with liver cancer. Can I not start treatment? And so what the guidelines recently said is, well, even for patients who do not meet the criteria for starting treatment, we can start them on treatment if the patient really requests and they understand the benefit, how much benefit they would get, and the need for long-term treatment. We just need to have a shared decision making as long as the patients understand what they're getting themselves into and they're going to be compliant. We're not telling you shouldn't be treating the patient. So you hear nowadays in medicine, oftentimes we say that doctors are not gods. In the past, when we're doctors, we say, "Oh, I'm the doctor, you should be doing this." And the patients would have to listen to us. But we recognize that time has changed. It's a partnership. And therefore, shared decision making basically means we first assess the virus replication activity, the degree of liver injury. Then we discuss with the patient. Now, if we don't treat you, what would be the chance of you getting cirrhosis or liver cancer in the next 5 or 10 years? Now, if we treat you, how much would we be able to reduce that risk? Because recognizing that, as I've mentioned, putting patients on treatment does not mean that the risk of liver cancer completely go away. And we have to be very honest, because sometimes patients think, well, you put me on treatment and everything is going to just be fine. No. The cancer risk is greatly reduced, but not completely gone. The virus might be suppressed, but not completely gone. So it's extremely important that the patient understand this would be a long-term treatment. Now, many of my patients say, oh, it sounds so complicated. I'm feeling well now. Can I go home and think about it? I'll send you a message. I'll call you if I decide to start treatment. Now, of course, 6 months later, a year later, they never call me. I see them back in clinic again and I said, well, let's talk about whether to start treatment or not. And sometimes some patients do need this discussion more than once before they're willing to commit to long-term treatment. But also, sometimes patients' preference change. As we get older, our preference might change. But also, the virus might become more active or less active. The liver enzymes might become higher or lower. So it is extremely important that we discuss with the doctor every follow-up visit. Hey, what's my situation now? Should we stay with the same decision that we had 5 years ago, or should we change? So that's the current status of treatment. Well, a lot of my patients say, I hear that you guys are working on a cure. Completely get rid of it. Completely control and eliminate all those risks. Are we there? Well, the first thing is, what do we mean by cure? Generally speaking, when we talk about cure, we say that, well, we eliminate every single trace of the virus. We completely wipe out any possible risk of bad outcomes, cirrhosis, and liver cancer. We don't think that this is realistic in the next 5 or 10 years. So what we've been trying to really aim at is, in addition to suppressing DNA, which is what we're doing right now, if we can find treatment that can help patients clear hepatitis B surface antigen, so going from positive to negative, in addition to the virus DNA being not detected, even when we take the patients off treatment, it doesn't come back. Because right now, you heard that I emphasize many times, don't stop treatment without talking to your doctors, because that virus in your liver might spring back. So what we're hoping is we can treat patients for a finite duration, 6 months, a year. We stop the treatment. The surface antigen is still negative. The DNA is still undetectable. That would be good, even though we know that there would still be possible traces of virus in the liver, and the liver cancer risk is still there. But studies have shown that in patients who clear not just surface and not just have DNA suppression, but also surface antigen loss, they do have additional benefits because the risk of liver cancer is further decreased. And our goal is to be able to get to a point where when we stop treatment, the virus does not quickly bounce back. So we eliminate the need for long-term therapy. I now have patients who've been on entecavir for 18 years, 20 years. And it's, yeah, although some people would say, gosh, I mean, when you treat patients with high blood pressure, they are also in treatment for 10 years, 20 years. As long as the treatment is safe and simple, it's not necessarily the end of the world. But we also hope that if we do have cure therapies and we're able to really treat patients when they're young and before there is any significant liver damage, and we then get rid of it, DNA gone, S antigen gone, even after stopping treatment. Maybe these patients not only do not need long-term treatment, they may not need to keep coming back every 6 months, every year for blood tests. Maybe they don't need to do liver cancer screening forever and ever. So these are the hopes that we want to achieve. But for many patients, they also tell us, I feel ashamed that I have hepatitis B. I don't want to let people know. I worry that they would not want to be my friends, not want to have dinner with me. And this would allow us to also remove that stigma so patients don't feel like I'm always someone that might pass the infection on to other people. But why is it so difficult to achieve a cure? Because hepatitis B is a very smart virus. It hides in the liver cells, and it can stay there and be stable for many, many, many years. And the treatment that we have right now, entecavir, tenofovir, they do not directly kill the virus. They just push it into a corner. And the virus DNA can also be integrated into our own DNA. So that's part of the reason how it can cause liver cancer, because it might cause disruption of our own DNA. But also in patients with chronic hepatitis B, the immune system somehow does not recognize that virus as foreign and is not very capable of fighting the virus. Now, I want to clarify, it does not mean that patients with hepatitis B have a poor immune response to other infections. It's just something that is in the system that they do not see the hepatitis B virus as an enemy, and they just let it sit in the body and leave it alone and not try to kick it out until a later stage in life when sometimes the immune system wakes up, or in some patients, it never really quite wake up. So how are we going to tackle hepatitis B and achieve a cure? Well, we're going to still need to stop the virus from making new viruses and new virus DNA, but we need to have specific mechanisms that decrease hepatitis B surface antigen production. Now, it's a little too complicated to get into why these two approaches are different, but one of the reasons is the virus has different mechanisms of making surface antigen, which is basically like the coat around the virus. In addition to the virus itself, it can also have a second mechanism to just make more coats for itself. But we know that in patients of chronic hepatitis B, because the immune system doesn't recognize the virus very well. Well, what if we also have immune modulatory therapy? Wake up the immune system, start recognizing that virus as your enemy, and start attacking that virus. That would also help. And so right now, the cure therapies really have a three-pronged approach. And most are going to really rely on combination of these strategies. So you suppress new virus DNA, you suppress new surface antigen production, and you wake up the sleepy immune system. So we hope that we will get to where we need to be. So where are we now? You guys have been talking about these trials for a long, long time. Yes, and there have been many trials that have been carried out. In the last 15 years, probably more than 100 clinical trials. Unfortunately, some of them proved to be not effective at all. Some of them proved to be too toxic with too many side effects. And so some of these drugs, some of these companies have gone bankrupt and disappeared. But there is potential good news because recently, one phase 3 trial had been completed, and the results will be available in the next couple of months. When we talk about developing new drugs, we first test the drugs in a laboratory. Sometimes we test it in animals, but usually from the laboratory, we take it to humans, and we go through phase 1, phase 2, and phase 3. If the drug proved to be effective and safe in phase 1 and 2, it goes to phase 3. These are the large trials with thousands of people all over the world. And if it is confirmed to be effective and safe, then drug companies submit the data to FDA, European regulatory agencies, Canada for approval. So at least we now have one that completed phase 3 trial. Unfortunately, there's only one that has gone into phase 3, and the others are still sort of in earlier stages. Well, they're not really like hepatitis C with 95% success rate. So far, the most successful ones are really like 20-30%, but that's really in cherry-picked patients who don't have cirrhosis, who have already low DNA or undetectable DNA to begin with, and who have low surface antigen level. And many of these new treatment involve injections. So there's no such thing as just pill form therapy right now. It's just a matter of whether the combination requires 1 injection or 2 injections. So even when this new treatment is approved, we don't know how many patients necessarily want to switch from 1 pill once a day to these more complex regimens. Now, of course, one could argue that if the new cure therapies can wipe out surface antigen in 50%, you'll be more enthusiastic. But if it's only 10%, 15%, then it would be difficult to really know how many patients would rather switch from oral therapy to more complex regimen. And there's also the practicality of cost, because entecavir, tenofovir, the generic versions right now, are fairly affordable. New treatment always will be very expensive. Now, would health insurance cover? Would the Canadian government cover? Or would the health policies restrict only certain patients would be eligible for these expensive new treatment? Time will tell, but at least there's hope that we have something moving along, which until a couple of years ago, we were wondering, are we ever going to get there?
Thank you very much, Dr. Locke. I think that is very, very informative.